Hello and welcome to Team 18's Process Improvement Project. Our project is entitled Paperweight Room to Improve, and as you may be able to tell from this play on words, our aim is to reduce the wait times associated with our clinical letters in the rheumatology service in Crumlin. Our team consists of 5 members who are all from different backgrounds and are all working in different healthcare institutions. We are all undertaking the Master's Programme in UCD and have never worked together prior to this project. This presented us with some unique challenges which we'll discuss in more detail later, but we adopted a person-centred approach to work together as an effective team on our improvement journey as we will describe. We undertook our process improvement project in the Paediatric Rheumatology Service in Children's Health Ireland at Crumlin. I am one of the doctors working in this service, and I'm actually the only member of our team working on this service, which as mentioned did create some challenges. To give a brief overview of the service, it was established in 2016 and it has since grown into a large multidisciplinary team caring for children with rheumatic and musculoskeletal disorders on a local and a national level. Juvenile idiopathic arthritis, or JIA, is the commonest inflammatory disorder of childhood that we deal with, and it is estimated that there are over 1,000 children in Ireland affected by this condition. Very importantly, uveitis, which is essentially inflammation at the back of the eyes, is one of the most common complications of juvenile idiopathic arthritis and is potentially sight-threatening. It affects up to 30% of children with juvenile idiopathic arthritis, and it is essential that they get seen by an ophthalmologist as soon as possible, given that any delays in its detection can lead to blindness. You will see that this was one of the priorities of the project that we undertook.
Thanks, Owen. First, we'll explore the define phase of our project.
To give an overview of why we selected this project, the management of children with rheumatic conditions requires multidisciplinary team input, involving the members of the multidisciplinary team within the rheumatology service, in addition to other healthcare professionals involved in the patient's care, such as general practitioners and general paediatricians. And the timely communication between these professionals is of utmost importance to achieve good outcomes. Currently, there are significant delays relating to the time it takes for patients' letters to be completed and posted out to other clinicians involved in the patient's care from our service. This leads to significant patient safety risks. Delayed referrals to other services, some of which might be urgent, in particular ophthalmology, can have devastating complications as mentioned. Additionally, GPs and primary consultants may not receive timely updates about patient care, such as any changes in medications which can lead to medication errors. Finally, parental frustration with delays and potential confusion about the plan is a significant issue. Finally, the delays in letters also generates additional workload for our secretaries and administrative staff in answering queries looking for updates about patients which would have been included in the letters. With this in mind, our project aim was to reduce the time taken for clinic letters to be sent to other clinicians involved in the patient's care following their rheumatology outpatient department appointments. We then transformed this to a SMART goal, which was to reduce the average time from dictation to postage of letters from the department from a baseline of 4 months median to a target of 2 months median by March 2023. Our SciPod gives a high-level overview of the process by which clinic letters are produced following clinical encounters with the rheumatology service. The first step is that the NCHD dictates a letter using our G2 software package. The letters then pass electronically onto the secretary's folder, who then type or transcribe the letters. The letter then passes electronically back to the NCHD review folder, who reviews and edits the letters as appropriate. The letters then all pass on to the consultant's review folder, who then edit and sign off the letters as required. And at present, the consultants review and sign off all of the letters produced by our department. The final step is that the letters pass back to the secretary's folder, who then print the letters and leave them out for posting. The key suppliers in this process are the NCHDs, who produce the vast majority of letters. The consultants also produce a smaller volume of letters, as well as signing off on all of the letters produced in the department. The nurses are key stakeholders in management of the patient care and produce a smaller number of our letters and are key inputs to the clinical care of the patients. The secretaries, who as mentioned transcribe the letters and also move the letters through each of the phases and then leave them out for printing, and IT support is provided for the G2 software package. The main output is a completed letter which is produced in a timely fashion with reduced variability and clear and accurate communication for the customers. Namely, the customers are the GPs involved in the patient care, the primary consultants who would have referred the patient to our service, as well as the receiving consultants for onward referrals, such as the ophthalmology consultants, as well as any additional health and social care professionals involved in the patient care. And patients and parents are obviously the primary customers or recipients of these letters. We additionally developed a project scope sandbox to highlight the components which lie outside of our scope. As described in the previous slide in our SciPoc, the letter begins at the step where the NCHD dictates the letter and it ends at the step by which the secretary leaves the letter out for posting. Any delays occurring prior to the NCHD dictating or after the letter being placed out for posting are outside of the scope. Additionally, the development of any new technologies or IT systems are outside of the scope of this project. To begin with, we defined, as shown in the SciPoc, the end-to-end current state process map, beginning with the dictation of letters on the G2 software program and ending with the printing and posting of the letters by our secretaries. This was developed using a Gemba by sitting down with each of the key stakeholders, and in particular the secretaries who had end-to-end oversight of the entire process. As you can see, overall there were 621 letters in progress on the system. Of these, 197 letters had been dictated but were awaiting transcription by a secretary. A further 73 letters had been transcribed but were awaiting review by an NCHD. An additional 262 letters had been reviewed by an NCHD but were awaiting sign-off by a consultant. And finally, there were 89 letters in the final phase awaiting completion and to be left out for posting by the secretaries.
Our data collection revealed that the median time taken to review letters by NCHDs alone was 4 months. This falls outside the recommended time period for ophthalmology assessment in JIA. Consequently, this delay in critical communication between healthcare staff may adversely affect clinical outcomes.
We encountered a number of problems as a team during this project, and probably the biggest of these related to the collection and analysis of data. The G2 software program does not have a facility for exporting data into Excel or to other software packages for analysis of data. As a result, this needed to be done manually, whereby we had to print out reams of raw material from the G2 software package and then analyse them manually. Additionally, as can be seen, the titles of letters used in the G2 software package were user dependent and there was significant inter-user variability. This led to challenges in analysis of the data. And in particular, say for example, the ophthalmology letters, which were a key priority for this project, were very difficult to identify and therefore to analyse. Finally, as mentioned, the 5 members of our team work on different sites and different teams, and only 1 member of our team works in the rheumatology service. Given the sensitive nature of the data, this information could not be shared between the people on the team and needed to be analysed on an individual basis, and this led to further challenges with the analysis of data.
Now let's perform a stakeholder analysis. We use the power interest grid as a tool to quantify the influence and impact of the project on stakeholders. As you can see, NCHDs, rheumatology consultants, advanced nurse practitioners, and secretaries all have a high stake in the project. Each group can recognize the impact of reduced clinical risk through timely dispatch of letters and referrals. Also important were GPs, which require timely updates on patients and their outcomes, in addition to consultants who are receiving letters and referrals from our patients. Finally, patients and families are important because they require timely access to care and interventions needed. Now for a stakeholder communication plan. To gauge the opinions and levels of satisfaction with the current system, we engage the stakeholders who are most closely involved with the process on a daily basis, namely NCHDs, rheumatology consultants, ANPs, and secretaries. It is important that these projects' stakeholders are supportive, as they have a lot of influence over the project. This engagement consisted mostly of face-to-face meetings, information sessions, and consultations with stakeholders. A staff questionnaire was also distributed. Next, let's discuss our project's measure phase.
Our data collection plan was a critical aspect to the measure phase of our Lean Six Sigma project. It provided a solid foundation for identifying areas where variation existed and enabled our team to make data-driven decisions. We used a visual control board to track progress and ensure that we met our goals. We designed the plan with a structured approach that included specific timelines and locations for data collection. We used various methods to collect the data, such as visual checks, process mapping, manual data capture, online questionnaires, and asking medical secretaries to count interruptions during their day due to process inefficiencies. The final part of our data collection plan involved refining the data set. This helped us identify the core sources of variation and prioritise our efforts as we move towards the analyse phase. By identifying the areas that need the most improvement, we can make targeted improvements to the process and improve its overall
We
performance.
undertook a literature review of a paediatric rheumatologic condition to inform our critical quality. Juvenile idiopathic arthritis, or JIA, is a common rheumatic disease with a reported incidence of 5.61 per 100,000 population in the UK. Excluding joint disease, uveitis or eye inflammation is the most common physical finding in patients diagnosed with JIA. As per Bernard et al. And their recommendations concerning the screening, monitoring and treatment of JIA, children should be referred for ophthalmology assessment within 1 to 3 months of JIA diagnosis. This is to mitigate the risk of permanent blindness in high-risk patients, which may be as a result of delayed ophthalmology assessment.
Patient Critical to Quality, or CTQ, emphasizes speed and reliability. Drivers of speed include transcription of letters by secretaries, review by NCHDs, further review and sign-off by consultants, and printing and posting of letters by secretaries. These 4 drivers can be quantified as median duration of each cycle time. Staff CTQ comprises of 3 fundamental needs: an efficient process, ease of use, and quality of service. An efficient process requires adequate staffing. It also requires functional equipment. Hardware can be repaired or replaced if required. Next, ease of use requires staff to be knowledgeable and satisfied with their process. Knowledge may require formal or informal staff training to use transcription software and hardware. Finally, staff wish to be proud of a quality service that meets their expectations, as demonstrated in the survey.
It quickly became apparent that there was significant variation in the process. One significant source of this variation was the absence of any standardization in the naming of letters within the system. We discovered that there are 173 different titles for the letters out of the sample size of 700. So 1 in 24 had a different letter name. This level of variation demonstrated the lack of a lean process, and it made analysis much more challenging. With such a wide range of letter titles, it was difficult to identify patterns and trends in the data and understand where improvements could be made.
Now let's analyze the results of the staff survey. We had a total of 7 responders who gave a mean clinical risk rating of 60%, in addition to a 67% average rating for timeliness and efficiency. However, these scores varied wildly between staff members, with a range between 0 and 90% for each score. Staff identified delays as the primary clinical risk. One reason for delays was a lack of dedicated time for NCHDs for dictating letters and for secretaries for transcribing letters. Routine and urgent designations were not mandatory. This led to delayed communication with the GPs, delayed referrals, and out-of-date letters. There is a lack of standardized templates and no sign-off reminders for letters that were completed. Finally, financial constraints, staff competing demands, and a lack of staff in a service-driven environment all contributed to delays in patient care. Now let's review the analyze phase of our project.
Our team reviewed the wastes associated and concluded that waiting, overproduction, overprocessing, defects and skills were within the project scope with respect to wastes. With respect to waiting, waste included transcription, NCHD and consultant review, as well as outstanding completion. By analysing overproduction, we noted non-value add in the unique letters dictated for patients diagnosed with the same condition referred to other medical or surgical departments. This highlighted the efficiency of a standard template where suitable. Overprocessing once again gave credence to the time saved by a standardised template where appropriate with respect to dictation, transcribing and review. Standardising letters was also posed as a means of eliminating defects through dictation and typing errors. Lastly, the underutilisation of NCHDs and the overutilisation of consultants for the sign-off of letters was deemed a potential waste. So, in order to facilitate further brainstorming regarding the root causes of the inefficiencies in this process, we composed a cause and effect, or fishbone diagram. Within machine, we noted that the manual process of transcribing a recorded dictation was time-consuming, but recognised that this was beyond the scope of our project. Materials once again highlighted the concept of standardised templates for certain patient cohorts, which would make for a more efficient process. We also noted that the use of software supporting non-paper-based communication would expedite communication between healthcare services, but acknowledged that the development of any new IT systems were beyond the project scope as set out by the defined phase. With respect to methods, we noted that the time taken for transcription review by non-consultant hospital doctors, or NCHDs, and final review by all consultants was an area for consideration. We postulated that a means of identifying letters suitable for direct NCHD sign-off may alleviate some of the delays hampering timely communication with other medical services. Lastly, analysing the manpower associated revealed significant issues regarding the need for further staffing with respect to all stakeholders. It also raised the issue of NCHD rotations and missed letters as a result of NCHDs changing jobs within departments. However, once again, these issues were beyond the project scope.
Next, let's explore our project's improve phase. To begin our improve phase, we started by brainstorming solutions. This included introducing sign-off deadlines and protected teaching time for NCHDs and secretaries for letters. We also thought about speech-to-text software, bypassing consultant review, letter templates, and more administration staff and NCHDs. Next, we used a pick chart to prioritize our ideas. We sorted ideas by difficulty on the x-axis and value or impact on the y-axis. We've identified ideas that both had a high value and impact and a relatively low difficulty as our priorities, and sorted these in the implement square in the top left. These included letter templates, protected time for secretaries, and bypass of consultant reviews.
This slide shows our implementation plan for our improvement project, with the status shown on the right as either green for complete, amber for ongoing, or red for the components that are pending. There are 2 phases to our project, beginning with the Phase 1 pilot programme. We focused on prioritising the development of a standardised template for the ophthalmology letters due to the risk of blindness associated with any delays in these letters. We have already developed the standardised template for these ophthalmology letters. We are in the process of rolling out the use of this new template, which will then therefore bypass the need for consultant sign-off given that it's a standardised template that's being used. We are also in the process of monitoring data related to the number of phone calls received by secretaries relating to the delays. And we are also establishing protected time for secretaries to focus on transcribing letters so that the delays are reduced, and are collecting data to support hiring additional staff as needed. Phase 2 of our project involves the identification of which other letter types would lend themselves towards developing standardised template letters for commonly occurring referral letters, such as referrals to orthopaedics. We are ongoing in this process. We are also developing standardised templates for the above letters, which is ongoing. We are due to commence the rollout of these new templates following lessons learned from Phase 1 shortly. And we are also looking to identify and agree any other letter types that might be suitable to bypass the consultant sign-off phase, given that this has been identified as a major bottleneck based on our data. This slide shows the ophthalmology referral letter template that we developed and is now being used in the rheumatology department.
Following a review of the areas of non-value add identified by our Tim Woods, we felt our standardised templates for suitable letters would lead to the most impact in waiting, overprocessing and defects.
Finally, let's consider our project's control phase.
Shown at the bottom of our implementation plan is the next generation component to this project. This lies outside of the scope of our current project, given the fact that I am the only member of our team working with the rheumatology service and I am due to finish up with them in July. We have therefore worked closely with the stakeholders on the rheumatology team to set out the plan for the future state project. This will involve the development of generalised letter templates for all other letters from the rheumatology service in order to limit variation in the letter content. This will also involve working with IT to build in red flag systems to identify any letters that exceed an agreed threshold wait time, as well as establishing periodic data reviews by working with IT to find options to automate data collection and extraction from G2 to Excel for analysis, given that the current data analysis was extremely time consuming. And data will also be used to trigger the need for more support from secretaries and typists as required if defined thresholds are breached.
One of the great strengths of this project has been our commitment to a person-centred approach to improvement throughout the process. The story of our team began 7 months ago and can be followed using Tuckman's model of team development: forming, storming, norming and performing. We came together last September through a process of random selection. 5 strangers from diverse backgrounds of medicine, engineering, industry and nursing, working in 5 different sites across the city. However, we were united in our universal desire to improve our ways of working and evolve the systems in which we work to improve patient experience and outcomes. We each recognised that successful projects are all about the ability of the people on the team to cohese, and that forming healthful relationships is the foundation of any process improvement initiative. And so, from an early stage, we consciously worked towards fostering a team dynamic of collaboration, inclusivity, and collective participation. As a team, we have never met in person, and our meetings have always been on an online platform. This was sometimes challenging due to shift work and conflicting schedules, and required compromise on everyone's part. Many different suggestions were put forward when trying to choose a project. Each potential project was respectfully considered. As a team, we looked for the improvement opportunities in each one and the value we could bring. We gathered perspectives and insights from across the team, considered the variabilities, then made our decision. This mutual respect and understanding provided us with a space where we felt psychologically safe to brainstorm, put our ideas and reservations forward, and nurtured our sense of creativity and innovation in how we would proceed. The collective input during this phase resulted in our project title, Paperweight: Room to Improve. The strengths of the various team members emerged, and each person assumed roles and responsibilities which played to those strengths and ensured that the team was greater than the sum of its parts. We did, however, encounter challenges along the way. We did not have a process owner on our team, and only one member of the team worked closely with the process in the rheumatology clinic and was in a position to have face-to-face engagement with the suppliers. In addition to this, we required the assistance of the clinic secretaries when gathering some of the data, but were sympathetic to their busy work schedules. As a group of professional adult learners, the commitment to the project competed with a range of other priorities and demands. Throughout the 7-month time span of the project, we supported each other through significant life events, periods of high pressures within our jobs, and the day-to-day demands of life. There have been real demonstrations of kindness, compassion and patience, all the while ensuring the project deliverables were on target and the morale of the team was high. Supported by our mentor, we adhered to the principles of a high challenge, high support approach to working together, which was both rewarding and empowering, and was a key success factor in carrying out this project. But evidence of person-centredness extended beyond our team and across the wider project scope. We carried out a SWOT analysis of our project specifically in the domain of person-centred practice. As you can see, the strengths are largely centred on positive stakeholder engagement, with a basis in respect for persons. It is important that we build on these strengths, as the disconnected nature of our work and geographical locations means we are reliant on others to ensure the sustainability of the project going forward, and we are mindful of the potential challenges arising from this. Finally, the goal of any process improvement project is to improve the outcome for patients whilst reducing the workload for staff. So in the context of our project, where is the value for service users and staff? Here are just some examples of the impact of our project on person-centred practice. For the non-consultant hospital doctors, the standardised templates will eliminate the need for consultant sign-off, which gives them a greater degree of autonomy and empowerment in their work. The standardised templates also ensure a degree of consistency in communications, thereby reducing the onus on NCHDs to generate individual narratives. This approach delivers significant time saving, which in turn ensures that NCHDs can dedicate their time to higher order work. With consultant sign-off no longer required for every letter, this will free up a large amount of time for the consultants to spend with the patients in clinic and carry out other essential work. For the secretaries, the standardised templates will mitigate against long rambling letters, speeding up the transcribing process. Protected time for typing will provide clinic secretaries with uninterrupted periods of time to focus on getting letters out in a timelier fashion and relieving any backlog. It also reduces the risk of secretaries staying late to type or working through their lunch break. The time spent answering the many calls from anxious families waiting to hear on appointment dates will also be less. For the parents and families, it will significantly reduce the frustration and distress experienced waiting for appointment dates, and reduce the amount of time spent phoning the clinic looking for updates. But most importantly, for the children attending Crumlin's Rheumatology Clinic, it will provide them with timelier access to the vital specialist care they need, reducing the risks associated with delays in treatment of conditions such as uveitis, potentially saving their sight.
On behalf of Team 18, we'd like to thank you for listening to our Oh my god. I swear this is how literally every one of our meetings ended. Finally, if you think you are too small to make a difference, try sleeping with a mosquito in the room.